Dr. Prashant, you can start your session.
Thank you. Good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room, the experience with Carbetocin. Today we have got Honorable Speaker, Dr. Archana Reddy with us. Welcome, madam. This program is brought to you by
Thank you, sir.
Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993, and we have 25 years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. Heathrow Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world and has Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients during COVID era, which is why, for in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, the experience sharing program on managing PPH. As I said, we have got Honorable Speaker Dr. P. Archana Reddy with us. Madam, welcome once again. Madam is MBBS DGODNB from Sri BM Patil Medical College, Karnataka. DGO from MRMC Gulbarga, Karnataka. DNB from Yashoda Hospital, Hyderabad. Madam has 15 years of experience as is consulting OB obstetrician and gynecologist at Lifespring Hospital and Nakshatra Hospital and consultant at Ankura Hospital. With this brief introduction, I welcome Dr. Archana Reddy once again and over to you, madam.
Thank you, sir. Thank you for the introduction, sir. Hello everyone. I'm Dr. Archana Reddy, consultant obstetrician from Ankara Hospital. And today we're going to talk on the overview of postpartum hemorrhage. So as we all know that postpartum hemorrhage is such a condition that even though all the obstetricians are prepared for it, but it's such a frightening scenario, like any part of the life we would have faced it. So, to define postpartum hemorrhage is a daunting effect. It is usually described when there is a loss of more than at least 500 ml of blood following a vaginal delivery or 1,000 ml following a cesarean section. Next. Okay. Next slide. So, as we all know, it's an unfortunate but yet a made common condition. So, usually the postpartum hemorrhage, it is a leading cause of maternal mortality. It is accounting for about 35% of all the maternal deaths. It is the MMR in developing countries is up to 244 per 1 lakh lives compared to the 16 in developed countries. The global PPH in incidence, it is almost up to 14 million women suffer from PPH. In incidence is reportedly as 2 to 4% after vaginal and 6% after a cesarean delivery. In India, approximately 38% of maternal deaths are due to PPH. Of that, 25.7% of the global deaths it takes place in India, and that contributes to approximately two-thirds of these attribute to the PPH. India has unexpectedly high maternal death rate of 540 per 1 lakh live births. So, coming to the etiology of postpartum hemorrhage, it might be due to any of the following factors, like it may be due to the tone, where the uterine atony it causes due to inability of the uterus to contract, which may lead to a continuous bleeding, or thrombin, if it is there any failure in clotting factors, which might cause, or if there is any uterine trauma, injury to the birth canal rupture and uterine inversion or lacerations, or if there is any retention of placental clots and any abnormal placental. So coming to the clinical findings in PPH, usually we can see, as you see in the following chart here, we can distribute the shocks as a mild, moderate, and severity. It depends on the amount of the blood loss. If it is usually 1,000 to 1,500 ml, which contributes to 15 to 25% of the blood loss, there will be a slight fall in the BP, and the patient may suffer with weakness, sweating, and tachycardia. If it is moderate, there may be a marked fall in the BP, and the patient usually may be restlessness, pallor, and oliguria. If it is severe, which is approximately 2,000 to 3,000 ml blood loss, contributes to 35 to 45%. There will be a profound fall in the BP, and the patient may have a collapse or air hunger and anuria. So in this, there might be like clinical, how can we see there will abdominal tenderness, we can see there will circulatory collapse or increasing abdominal girth, which we can measure, or there is any loss of uterine contractions or maternal tachycardia or increased vaginal bleeding. So how do we approach? So approach towards the postpartum hemorrhage. First, we should see the uterine atony, whether it is a normal or a cesarean delivery. First, we should see whether the uterus is well contracted or not. If it is not contracted, then we should see why we can start it. We can do a blood picture and all investigations, routine investigations, which we can do. And we immediately start on uterotonic agents like oxytocin, prostaglandins, or ergotulgalides. Or you can finally as a last episode, we can go for uterine balloon tamponade. And if there is any tear or trauma which is expected during a normal or a cesarean delivery, if there is any tract injuries during a normal delivery, we should repair then and then so that we can notice this where the bleeding has started. And if it is in a delivery that is a trauma, if it happens during a cesarean section, then we should see whether there is an extension of uterine angles is there or any hematoma is there. So we have to externalize the uterus first, then see where the trauma is there. If anything is there, we should detect and so that we can repair it immediately. Investigations we can do by the exteriorization of the uterus, and lastly, we can with the help of an ultrasound. And there is rupture or any repair of identified genital tract injuries should be done. And if later on, we can take the help of any surgery if it is necessary. If there is an issue of a retained tissue or placental bits are there, so we should identify it during bimanual examination, or we can explore it under a general anesthesia, and we can explore it followed with a DNC or anything we can done, followed by an ultrasound, so that we are assured that there are no products are remaining. If in spite of all these things, that still the bleeding is continued, it might be due to a continuous bleeding or the contracted uterus in spite of the bleeding is there, then it might be due to some collagen abnormalities might be there. So you should check the investigations like urea and electrolytes, full blood count, relation profile should be taken, and medical management, if it is not helping out, then we have to substitute with the blood and blood products, and the final we can put management. Attempts should be made to identify the cause in women who are bleeding in parallel with resuscitation. So now we coming to the rationale for the development of carbetocin in new heat stable formulation. Carbetocin is available in a room temperature, which causes stable formulation and convenient vial presentation. It is stable at a room temperature, has a shelf life of 24 months at 30 degrees centigrade and 75% humidity. It avoids need for the cold chain storage and logistics. It is provided in a vial, whereas the oxytocin and ergot should be kept in a refrigerator to avoid degradation. Heat stable formulation of oxytocin is currently not available. Previous formulation of carbetocin should be stored between 2 and 8 degrees centigrade. Resource poor countries do not always have cold chain transport and storage capabilities. So use of ietrotonic agents. So now the common molecules which we use are oxytocin, carbetocin, ergometrin, syntropentrin, which is a combination of 500 micrograms ergometrin plus 5 international units oxytocin, or a misoprostol. Usually we administer them at the time of crowning of baby's head, at the delivery of anterior shoulder, at the end of second stage of labor, following the delivery of placenta. It is used mainly as a prophylactic usage in the prevention of PPH, active management of third stage of labor, or like therapeutic again in the management of PPH. So carbetocin, it is a synthetic long-acting analog of oxytocin. It is a next generation drug mainly used for PPH management. The therapeutic indication is given in prevention of postpartum hemorrhage due to uterine atony, and usually while contains 100 micrograms of carbetocin in 1 ml solution of injection. It prolongs carbetocin was created by making several modifications to the oxytocin structure so that it prolongs the half-life, it reduces the enzymatic degradation. So now we are coming to the efficacy of the oxytocin compared to the heat stable carbetocin. So usually the heat stable carbetocin, it is a long acting synthetic analog of oxytocin with agonist properties. It binds to oxytocin receptors in the uterine smooth muscle, resulting in rhythmic contractions, increased frequency of existing contractions, and increase the uterine tone. It is given in IV form and sustained uterine contractions within 2 minutes, lasting for about 6 minutes and followed by rhythmic contractions for 60 minutes. IM it's given in sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes. Its half-life is 40 minutes. Storage condition is up to 30 degrees centigrade. It is usually given in the prevention of the PPH. But in oxytocin, it is given as synthetic cyclopeptide form of the naturally occurring posterior pituitary hormone. It binds to oxytocin receptors in the uterine myometrium, stimulating contraction of this uterine smooth muscle by increasing the sodium permeability of uterine myofibrils. It is given as an IV, almost immediate action with the peak concentration after 30 minutes. IM is a slower onset of action, taking 3 to 7 minutes, but produces a longer lasting clinical effect of up to 60 minutes. Its half-life is 1 to 6 minutes. It requires protection from light and hence storage should be done at 2 to 8 degrees and continuously to preserve its activity. Oxytocin, it is also used in the induction of labor, augmentation of labor, and it is given in the prevention and the treatment of PPH. So there are now trials, it is called as a champion trial, WHO champion trial, which is the largest clinical trial in the prevention of the PPH. It is conducted by the WHO Department of Reproductive Health and Research, where the study design is like it's a non-inferiority double-blind randomized trial where the objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Around approximately 30,000 women were enrolled across 10 countries, including India, of which the primary outcomes, the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents was done. The proportion of women with blood loss were at least 1000 ml. So now within it comparatively, the blood loss of more than 500 ml or the use of additional uterotonic, in this the carbetocin efficacy was 14.5%, oxytocin was 14.4%. So in the blood loss of more than 1000 ml, it is 1.51% in carbetocin and 1.4% in oxytocin. So the frequency of the expected age did not differ significantly between the two groups. So the frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus the oxytocin. The use of additional uterotonic agents, intervention to stop the bleeding, and adverse effects did not differ significantly between the two groups. To further conclusion, carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. So there was a study with the Cochrane review where the carbetocin for the preventing PPH was done. There was a review data from 11 studies involving 2,635 women were included, in which there was concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for the therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. So the guideline recommendations for PPH approaches was recommended by WHO in 2018, where carbetocin was included as one of the following uterotonics. And in SGOC Canada, which in 2009, and FIGO, carbetocin was used as one of the recommendations for PPH management. In FCOG France 2015, carbetocin on proving non-inferior to oxytocin, which was achieved by the champion trial.
Since
So
how long you have
finally,
been
I found it,
using? Since how long you have been
sir.
using carbetocin?
Since 2 3 years, sir, because I have felt the carbetocin is acting literally very good compared to a routine traditional which we're using like ergot alkaloids and this in oxytocin. Nowadays, like it has in our setup, it has replaced all these drugs. So we are
Correct.
using it as a first line of management.
You are using as a first line management of that is prophylaxis
Yes, sir.
for. And you use it when the baby is delivered or
No, so usually I after the baby is delivered.
after the baby is delivered? Yeah, but
Yes.
that's when the PPH will actually start.
Yes.
And you generally use IV or IM?
IV, sir.
IV.
Yes.
Irrespective whether it was a vaginal delivery or a cesarean
Yes, sir.
section.
Yes. Yes.
Some of the questions we'll go through. Is the incidence of PPH more in India? It's said. Why any specific? Or it's the unawareness or not bringing the patient to the doctor?
Because India, first of all, there were no regular checkups, no antenatal
Yeah,
regular checkups will be there because of the
correct.
poor infrastructure, and because the anemia is very much prevalent in India. So
Yes,
that even though the baseline HB is less, so if it is a small amount of PPH also it leads to this
absolutely.
thing.
It can
Yeah.
destroy the hemodynamics, even with
Yes.
little loss. Correct. That's why the PPH is probably more I mean, people frighten, afraid of PPH more.
Yes, sir. So that's a very scenario which we all face.
Yeah. I will tell you when I was working in the remote of Mumbai, the highest hemoglobin I ever got was 5 and 5.5. I'm talking about the late 70s, of course, but then I don't think things have changed much.
Oh, no, but still, occasionally we are seeing that much also, sir. Even though the
Yeah.
patients, like, they are, even though they're not compliant also, still now.
And the worst part about these patients I've seen, madam, is that they don't give past history properly.
Yes.
That's the worst part. I mean, past
Yeah.
history of hypertension or diabetes during, or even PPH. They will not say, little bleeding here and there, I mean, but they don't realize that probably.
Mm.
What are the patient profile where you can anticipate a PPH? Although you can anticipate PPH anywhere, but then,
So we should be, yeah, PPH can happen anytime, even though we are
yeah.
mentally and prepared. But usually, like, if the patient is anemic, so that we have the more risk. If it is a patient is a, like pregnancy-induced hypertension, it is related, is there any twin pregnancy or any
Correct.
previous histories of PPH, we
Correct.
should be like well aware and be prepared for that.
And I expect the unexpected is a term which is very well applicable to gynecology, especially PPH. Any patient, a
So
normal delivery can just slip into that PPH.
yes, sir. Yes,
Yes.
yes. Multigravidas, we don't know when they
Absolutely.
suddenly land up in that.
Correct. My daughter-in-law, she was having twins, and the only thing I was afraid of this PPH.
Yes.
Is anemia considered a serious risk factor? Of course, in India, this is very
Sure.
true.
Yes, sir.
For prophylaxis of PPH, which are the drugs which don't normally use? Oxytocin, of course, yes. Carbetocin, besides oxytocin and carbetocin, anything else you use for prophylaxis?
So I prefer misoprostol also.
Misoprostol. That's effective for
Yes.
prophylaxis also.
Yes, sir. Because during immediately after the delivery, we are keeping internally in the cavity, uterine
Okay,
cavity, so
okay.
that by the time we closure and all that action will come, so the blood loss
Okay.
is limited.
There's
Yeah.
local action incident. Correct.
Yes.
Do you use carbetocin for prophylaxis of PPH in all patients or only patients at high risk?
Previously in high risk patients, sir, but now because we are using it for almost all the patients.
Absolutely, because it will make sense. Now, the best drug and PPH is
Yes.
one thing which should never one doctor should never have, but you never know how serious it can be.
Yes.
You generally prefer IV route, but any scope and place for IM route? I'm asking essentially asking because of audience. Some of them may be in the interiors, remote, where IV facilities may not be available all the time.
So in our setup, like even the anesthetists also prefer because surgery
IV,
time, any of
yeah.
the person who are administering the anesthetist, they are preferring IV route only. Normal delivery is like if it is there and we are worried, then we can go for an IM route to be on a
IM.
safer side.
And slightly on the, it may have a slightly longer duration of action also, duration of
Yes.
effect also.
Mm.
How fast it acts by IV? Your practical experience, apart from what is written in the documented.
So naturally, the IV route is much faster. Hardly
Faster,
we are
right?
seeing within 1 minute only that the action has
Okay.
been there.
So good.
Carbito IM, I think it is taken from 4 to 5 minutes.
Little. So what is documented in the journals is actually seen by the doctors is a great thing.
Yes.
Any experience of using it in RH negative mothers? Maybe?
The difference, so like according to the
Yeah.
protocols also, we are
Anyways,
giving it
we
for
use
RH
ITD.
negative also. Yeah.
How frequently you see a PPH even after using a carbetocin?
It is very rare. So it might be because of the other factors, like what we have discussed in the etiology, like
Yes,
not for the uterine atony, it works, carbetocin acts very well. But if it is any traumatic injuries or any
absolutely.
coagulopathy related,
Yes,
then
yes.
carbetocin would be
Those
much,
causes are, yes,
much
yes, yes, yes.
use.
Carbetocin will not work in any of those causes.
Yes.
Correct. And then we have to use tranexamic acid and all those measures.
Yes. Other we have
Yeah,
to
yeah,
go
yeah.
for other options.
And suppose if a PPH occurs in spite of using carbetocin for prophylaxis, do you feel that PPH could be less severe?
Initially, it affects no. So initially, the
It affects.
carbetocin will
Yeah.
act so to reduce the PPH. Then
Yes.
later on, we have to shift to the other conditions.
Absolutely. You have to check other
Then we have
conditions
to go
and
for.
then yes,
But
yes.
initially, yes, the amount of PPH at least it will be controlled.
Reduced. Yes. And what is the advantages of using carbetocin over other uretonics or PPH prevention, both in cities and metros?
So because nowadays, if you're using carbetocin, single drug is
Yeah.
sufficient. So we don't need to use additionally. Like previously, even though we are using for oxytocin, we would have given additionally
Yes.
aggregate alkaloids like methergine. We
Yes.
had to give prostadine also. Sometimes we had used to give and
Yes.
misoprostol also. So that at least that number of drugs is reduced.
Yes. Possibly cost also along with that.
Yes, sir.
Yes.
That matters.
Yeah. How it's tolerated in your experience? I mean, you have been using it for so long. How it's tolerated generally?
Yeah, means I didn't notice any side effects and
No,
so
it's
till
very
now that
good.
is
That's
okay.
very
But
great.
yeah,
The
yes.
condition is such, and it will be beneficial if you use carbetocin as a first line for PPH in every patient.
Yes, sir, because we have seen there is a dramatic reduce in the PPH, so we are not using any other drugs. And even though like we have used as prophylaxis in anemic patients, so we don't need to use any other iron
Absolutely.
supplements or iron
Yes, yes, yes,
injections
yes, yes.
that is reduced by that.
And I do not know, I've seen, even in Mumbai, not recently, of course, when some time back, patients used to come to the doctor in 6 months or 7 months, many times,
Mm.
peripheries of Mumbai. Nowadays, it doesn't happen, but I mean, that late. So correction of anemia is not very easy at that time.
Yes, sir.
To conclude, what is your overall take-home message for the audience, madam?
So we have been using for so long. We have seen no any side effects with the carbetocin. It is well appreciated and tolerated with the drugs. And I think it is a very ideal drug for the prevention and for regular use also.
Very good. Madam, thank you so much. Thanks for taking time. And
Thank you, sir.
I'm sure the doctors have benefited out of your sharing your experience because that's what doctors want, confidence from our own doctors. Thank you. Thanks all the doctors who took time and attended this. Thanks, madam, once again. Thank you, IT
Thank you,
team.
sir.
Thank you, marketing teams. Thanks, Sanjana. Thanks, Tanvi. And thanks, sales team for super coordination. Thank you so much, madam. You can log off
Thank
now.
you, sir.
Sign off. Thank you so much. Wish you a very pleasant afternoon. Thank you.